Hi, everybody. I'm Steve Paikin, and we welcome you once again to historic Hart House on the downtown campus of the University of Toronto for our final broadcast in the Agenda's special week of programming on the latest thinking and advances in the field of mental health. We've got several ways for you to be involved with our broadcast, and we hope you'll avail yourself of some of these. We are live streaming right now at the following website, tvo.org/Mental Health Matters. We're also hosting a live chat at tvo.org/Mental Health Matters. Tweet us if you want on Twitter at #TheAgenda or #MentalHealth, and chime in with your thoughts, and please join the conversation. And now to our conversation tonight about the power of words in the treatment of mental health. And joining us for that, Jennifer Chambers. She is the coordinator of the Empowerment Council. Dr. Thomas Unger is the chief of psychiatry at North York General Hospital. Jeffrey Riom is Associate Professor in Critical Disability Studies at York University. And Marianne Andaloro is mental health consumer and advocate who has bipolar disorder. It's great of all of you to spend some time with us here at Hart House as we try to get a better understanding in our last broadcast here of the issues we've been talking about all week. The term mentally ill, I want to start there. Is that an appropriate term to use, Jennifer?
I don't like the term. I believe it's an analogy gone wild. I think it was originally formed partly to get away from the idea that people are to blame when they're struggling mentally or emotionally. However, I think the over-reliance on it has led to an over-assumption about people's problems being biologically based and an overuse of pharmacy as a solution to all of people's problems.
Marianne, how about you? The term mentally ill.
I think there's a lot of negative connotation that comes with the term. There's a long, unfortunately, negative history to psychiatry as a whole. And I know myself with bipolar disorder. I consider myself as having a brain disease of some type as a result of malfunctioning neurotransmitters in my mind creating this disorder.
So you wouldn't want to be referred to as being mentally ill or having experienced mental illness. What would you prefer?
What I would prefer would be to be considered someone who has bipolar disorder specifically. And I make that distinction as I often hear the reference of someone being bipolar. And I see their distinction being not part of my identity, but it being a disorder itself.
Gotcha. Jeffrey?
You know, I don't like the term mentally ill either because it reduces someone to a biological collection of amoebae of some kind, and I think it's not a good way of understanding different people's experiences. It ends up pathologizing everybody with that particular term. It's better to ask people what they would like to be referred to as, I think, than imposing a term which has a history that's very, very negative. It's also a term that's only been around for the last 100 years. So when you think of people's experiences of madness, historically, a term like mental illness, they would know what you're talking about. So I think today it tends to marginalize people more than it tends to include people.
Now that's interesting. You use the word madness there. Mm-hmm. Is that okay to use?
Yes, for me. Not everybody likes it. There are some people who do. I actually teach a course called Mad People's History, and I do use a discussion, and there is also Ryerson, York teaches a course, so does Ryerson, and lots of other people. There's a Mad Student Society, for example, lots of other people use the term, have become using it, and historically I think it's a term that should be used more because it reflects the experiences that are beyond a biologically deterministic way of looking at it. There are people who have made it clear to me they don't like the term. I don't like to be called mad, and that's something we of course discuss and debate amongst each other, but I think for people who want to be called mad, that should be respected, and it's also, I think, very inclusive and empowering for many people. Mad is bad has been something that has happened throughout our history. Mad can also be something that's good, that for people to reclaim, to understand their experience, and above all, not to be ashamed. Those of us who have had experiences, however one defines it, as either mad, mentally ill, psychiatric disability, whatever term, it's nothing for any of us to be ashamed. So it's a way of reclaiming it.
Let me get Thomas Unger on this. What do you say?
You know, this is just a great example of just how confusing it is for providers to try to be respectful and figure out what to call these things. We have to use a name. You have to call it something. So I try not to get overly fussed about what the term is because I don't associate that term with the person. They're just a descriptive term we're using currently to describe a group of symptoms, and enables us to do research and to target our treatment. So it's a communication term. It's not what I think a person is in terms of how I use it. Unfortunately, the term mental illness to me does cause a lot of problems, not only for the people receiving treatment, but for the providers. Because within the healthcare field of medicine, it puts us on the wrong side of the fence in terms of what's legit and real, the organic or the body stuff, and the mind stuff that they've called functional, going back to Rene Descartes' splitting of things. So I think whenever you use the term mental, there's a whole bunch of associations and feelings, and everyone gets the willies, and everyone gets uncomfortable. There's all kinds of strong feeling from providers to patients to the public, and misconceptions as a result. So I wouldn't mind better terminology, but the question is, what would that be?
Well, Marianne, let me follow up with you on this. There's another scary word out there, cancer. And people who've had cancer, at least most of the ones I know, would not object to being self-described as a cancer patient. And in fact, if they've beaten it, they call themselves cancer survivors. How come that's okay, but being described as somebody who's beaten mental illness or dealing with mental illness, that's not?
I think in my particular case, bipolar disorder is a lifelong condition, so I'm not going to beat this. I will struggle with this illness for the rest of my life. It will not always be a struggle. There will be times I will be well. But for me to say I'm a mental health consumer, and I did, specifically choose that to be my title, is because I don't see myself as a survivor, as I will not beat this illness. I will simply find a comfortable way to function while working with medication and all the other treatments that I will require.
So you were, I guess, in the same way that CAMH describes the people who go there as their clients.
Clients, right.
As opposed to patients.
Right.
These words matter.
Yes.
Jennifer?
I think the other problem with mental illness is it's just not accurate for a vast majority of people. There's a misconception that there has been established a link between major psychiatric labels and biological conditions. And the reality is there has never been a clear cause and effect link established between any psychiatric diagnosis and a biological condition. There's links, there's correlations, but people's chemistry also changes according to their mood. Their chemistry changes according to whether they've been traumatized. So to call something an illness suggests a certain way that people have arrived in that state. So it's just inaccurate. You can refer to something as a disability, and people come to it by many different means. So for people who identify as having a disability, that's a little bit more inclusive, but that also does not include everybody who's ever struggled with mental health problems.
Well, let me get the medical man on this one, because while words are important and we want to be respectful, they also have to be accurate. Do you have an issue with somebody, for example, who goes to CAMH being described as a client as opposed to a patient?
I'll work with whatever terminology people want and respect. But
that's very progressive of you, but what does the profession think?
I looked up the etymology of the words actually in preparation for this, and actually I think that the word patient is actually a kinder term because it speaks to a person suffering with a health condition. Many of those other terms are more consumer goods related terms. So I use the term patient. I don't see it as being a problem because I just want to help people. And I think most of my colleagues want to do the same. So I don't feel quite as strongly about that terminology. I think it's terrific, and I actually do think I'm treating illnesses and disease states that we just haven't fully unraveled, as we've done historically in other medical and health conditions along the way for a large portion of the very severe conditions we treat.
Marianne, we just had somebody in the live chat following us right now on the web say they like living with depression better than a mentally ill patient.
I would say I would prefer to say that I am living with bipolar disorder. It's not part of my identity. I'm not. I feel less stigmatized using that terminology.
When were you first diagnosed?
I was first diagnosed in 2005.
2005.
But the symptoms had been exhibiting themselves from a young age. We just weren't aware of it.
And the symptoms were what?
Symptoms were moodiness, considerably more in the depressive phase of the illness, but had my first hypomanic episode in my late teens, had another one in my early 20s, and then I had a psychotic break in 2005.
And again, for those who don't know, a psychotic break would involve what?
So a complete loss of touch with reality. And I was unfortunately diagnosed antidepressants as depression had first presented itself at that time. And that is contraindicated with bipolar disorder. So it unfortunately put me into a manic episode. But the good outcome of that was I did get a proper diagnosis. and I've received the appropriate treatment and lived a very stable life for the most part ever since. I certainly have times that I'm unwell. I've just received a 3-month treatment for depression, but we've worked through that quite successfully, and looking forward to a long time of wellness for myself.
So you're much better off now.
Much better off now, and receiving a diagnosis was one of the best things that ever happened in my life.
When you first got that diagnosis, how did you react to it?
Oh, it was hard. It was hard to take. It to me at the time was one of the worst possible things that could happen to me in my life, and that's really how I felt at the time. And I would say it took about 6 months for me to really accept and understand what that was going to mean for me in my life. But it was truly life-changing for the better, and my life has been better overall, financially, emotionally, in relationships, in every aspect of my life, now that I understand what it was that was going on for me prior to then.
Jeffrey, can we talk to you a bit about your experiences with the mental health care system?
Oh, sure. When I was a teenager, I was in a couple of hospitals. So it was back in the 70s. I had a diagnosis of schizophrenia when I was 14, although I have to admit, I hadn't the slightest clue what schizophrenia meant at the time. So when the doctor said it, it meant nothing to me. What clued me into something was wrong, that I was different from others, was that I was told I was emotionally disturbed. That's what really did it.
That you
and when
understood.
you're 14, that has some cachet. Schizophrenia, I didn't know what it. My parents, of course, were devastated. That they understood. I always remember their reaction. They were very upset. Thank God I had a supportive family and parents. Otherwise, I wouldn't be here.
So
I credit them.
schizophrenia presented itself how with you?
Well, the thing is, I didn't necessarily feel I was schizophrenic and pop up, and when I think of it retrospectively on the one hand, but what they diagnosed me as schizophrenic is because I heard voices. I heard on an earlier show about people hearing voices. I heard the voices of my deceased Mimi, who was my father's mother. She was French-Canadian, so we called her Mimi. I heard her voice when I was a boy, and this was put down as, we were very close. She died when I was 9, but I always remembered her with great fondness, and her voice actually was not anything that was upsetting to me. I just heard her voice. She was a wonderful grandmotherly voice that I heard, and I didn't see anything wrong with that, but that was seen as something negative. But there were other serious problems. I'm not in any way saying I wasn't having difficulties. I had tried to commit suicide and had been doing some other things that weren't very good for my life.
You've been dealing with this, though, for a couple of decades, I guess, eh?
Yes, that's right. So there were legitimate reasons that my parents were concerned.
And how are you doing now?
Sure. 100% better.
How come?
That's a good question. I think the main reason is because I had huge amounts of support as a person with a very supportive family and a supportive background. I'm from Windsor, Ontario originally, and I was able to get different levels of support in the community, particularly in my family. And I was in the hospital a couple of times when I was 14 and again when I was 16. And I also have to say one thing that really made an impact on me. Like all 14-year-olds, you're complaining about this and that, you know. But as a 14-year-old, I saw other kids I was called a place called Regional Children's Center in Windsor, and their parents, some of them, treated them awful. I mean, like dirt. And I thought to myself, boy, what am I complaining about? Like most 14-year-olds, we complain about our parents, but my parents loved me and supported me. That had a huge impact, and also support of other people that I knew in psych facilities.
Okay, let me go to Jennifer beside you. Jennifer, I guess full disclosure here. You and I have known each other for a very long time. We haven't seen each other in a very long time, but we grew up on the same street in the same neighborhood in Hamilton.
We did.
You've had experiences with the mental health care system. Is there anything you want to share with us?
Like 1 out of 5 Canadians, I've had contact with mental health services, but I no longer tell my story much, and that's because there's a tendency to treat people who are in the systems or working on behalf of people who've had experience as people who can only tell their story, as opposed to providing some sort of thoughtful analysis of mental health services. And so I've gotten away from kind of the show and tell approach, although I do think it has value. I mean, some of the things that have happened as a result of the thoughts and analysis of people with direct experience in the system is that, for example, the mental health system now acknowledges that there's quite a high recovery rate for things that previously were thought to be lifelong, like people who've been diagnosed with schizophrenia, for example, there has been what's considered to be complete recovery, which sometimes is related to medication, sometimes unrelated to medication. So I think that actually hearing the thoughtful analysis of that people can bring based on their own life is sometimes a very important voice to include when developing policy and practice in the mental health system. And that's what I try and do with the organization for which I work.
So just again, in comparing some of the language here, we've heard Jeffrey say he has no objection to talking about a madness he suffered from. We've heard different language from Marianne. How would you, when you are sort of forced to describe to people what you've been through, what do you describe it as?
I just describe it. I'm someone with a personal experience of the mental health system. I use all sorts of different terms, actually. I'm not really wedded to one particular term. The only terminology I stay away from is medical model terminology, because I feel that it's inaccurate.
Gotcha. I want to read something here. This is out of the National Post from about middle of 2011. And it's an excerpt from an article that dealt with the death of Ashley Smith, who was incarcerated in the Grand Valley Institution for Women in Kitchener. Very sad story, many of you may remember. Here's the excerpt. Smith died in October 2007 after she tied a ligature around her neck at the Grand Valley Institution for Women in Kitchener. It's contested whether the mentally disturbed teenager meant to die or was just repeating an attention-seeking behavior that was not stopped by prison guards who witnessed the incident. Jeffrey, let me go to you first on this. In the media, obviously, we try to avoid jargon and be very direct with our descriptions, and we can't always ask a person how they want to be addressed. So what do we do about this? This sort of tightrope that many people in society walk. We don't want to be politically incorrect, but we don't want to be overly politically correct either. Give us some advice here.
Well, for the example of the young woman who died, Ashley Smith, it would have helped just to talk to her, and for the jail guards, the correctional facility people, just to communicate with her. I think that's the most important thing. I think the people who help those most are people who communicate with you as a person rather than just simply see you as a certain diagnostic label or somebody who might be faking it. I mean, it's a pretty serious thing if the person wasn't faking it. So obviously, I don't think it would be wise to take that sort of a risk because you're risking that person's existence.
Thomas, can you give us some advice on this?
Yeah, so I hear the terribly tragic story of somebody, and that speaks to the lack of information and understanding about what do you do when someone's in a state of disturbance and where are they getting treatment, and are people informed enough to know which way to direct them, whether it's to a criminal justice system or to a healthcare system. I actually have a little model where I've seen every health condition go through 4 stages, and that historically, the first stage being enlightenment, understanding that a set of symptoms is not demonic possession or punishment from the gods or something like that. It could be a health condition. And much of our society, many other cultures are still struggling for that enlightenment. Then we get a bunch of symptoms, we give them a name, we cluster them together. And right now we chose some not very good names in psychiatry, in my opinion, because I live in Toronto, the Leafs lose, I'm depressed. And yet we've given that name to mood conditions, so that inherently confuses people. And then we argue, are there 8 or 9 symptoms? Is it 2 weeks or 1 month of symptoms? And these classification books argue over where to cut them. But nevertheless, we have to cluster them to try to understand, are these real entities? What else is going on? Not that the experience isn't real, but as a physician, I want to know, is there something else going on? Then we move to the next stage of understanding with science, basically understanding the pathophysiology. What else is going on here? If it was your belly, what else is going on here? Is there appendicitis or a gallbladder thing? And then we invented an ultrasound machine to try to sort that out for us. So we're kind of trying to understand the pathophysiology, what areas in the brain, limbic dysregulation, chemical disturbances. So we're kind of struggling with what is first a label to then see what else is happening in the neurological and other system, but we haven't shifted the names. And then ultimately the holy grail is the etiology, knowing what causes it. Ulcers 10 years ago were thought to be due to stress, and the ulceration described the little hole in your stomach. We discovered they're due to bacterial infections the majority of the time, and now we use an antibiotic to treat them. So you see these things move through the stages. So the use of words and labels in this kind of descriptive term, in this symptom clustering, syndromatic, doesn't mean I think a person is that label. It's just the state of our understanding at this point as we start to dabble into some neurophysiology. So that's a medical model. That's what I'm trained in. So I don't ascribe that to it. And I hear the sensitivities, but I hope I don't come across as suggesting I think a person is in any way what that term actually is just currently used as.
Jennifer, you wanted to come in.
Speaking of language, that attention-seeking behavior is the kind of language that I hate in the mental health system. People use it all the time, and I think the reality is that people often need attention, and we don't have enough attention for everybody who needs it, and that is unfortunate on our part. It's not because the person is wrong trying to seek the attention that they need. She obviously needed attention.
I want to read another thing now. This is from Aaron Anderson's piece in the Globe and Mail from earlier this year, when we talk about fear and stigma, because that's a huge part of our conversation today too. Stigma is a term bandied around so often that it has taken on the quality of an incurable disease in its own right. In 1963, Canadian psychiatrist Irving Goffman wrote a classic definition of stigma, calling it, quote, spoiled identity that disqualifies an individual from full social acceptance. There are undeniable issues that develop from a diagnosis of mental illness, especially when symptoms are acute and untreated. People suffering from depression and anxiety have, unsurprisingly, higher rates of absenteeism from work, are more likely to self-medicate with drugs and alcohol. In the manic stage, people with bipolar disorder often behave erratically, experience delusions, or make reckless financial decisions. When Vincent Lee beheaded a stranger on a Greyhound bus in Manitoba in 2008, his diagnosis of schizophrenia and the media frenzy his gruesome act generated only heightened a public fear of people suffering with psychosis. Let's get into stigma. Jeffrey, how about to you first here? Have you ever experienced stigma because of your mental illness?
Yes, well, when I was a teenager, certainly, I did. And in fact, most of my friends were no longer my friends after that time. And I have to say, to be fair to them, had I been in their shoes, I wouldn't have been any different.
Why do you say that?
Because the prejudice towards people with a psych history, or prejudice with anybody with any sort of cognitive or psychiatric or intellectual disability, was so profound that it was taken as a given. And I don't pretend to be Mr. Innocent here. I had those prejudices too until it happened to me. And so I have to say, honestly, if I were 14, I wouldn't have been much different. So I think it was wrong. It wasn't right, but unfortunately, that was often a common thing. What I find unacceptable is the adults who perpetuated it.
Kids is one thing, adults is another.
Kids are growing up. We all learn. But adults, it's inexcusable. And that's where I find, and I've heard teachers, as a teacher, when I was a kid, I heard teachers making bigoted comments.
Now, this is a quarter century ago, though. We better off now?
Do teachers no longer make prejudiced comments towards people with psych history? As a professor at York University, I have to say, I'm sorry to say that I've heard from students that they have had experiences of prejudice in the contemporary times, not just quarter century ago, about teachers making prejudiced comments.
How about you as a professor at York University today? Do you still suffer from stigma from others, colleagues, students?
No, I'm extremely lucky, to put it mildly. I have an elite position, as I've said to some of my friends and family. I've got an elite position, I'm going to use it. It's been used against those of us with a psychiatric history for generations. Well, I'm in a position, so I'm very, very fortunate where I can be open. I was open beginning in 1990. Actually, Jennifer, whom I've known since 1990, was at a group called the Ontario Psychiatric Survivor Alliance, and that's when I started first getting open as a PhD student. Before then, I actually, to be frank, I lied through my teeth when people asked me about certain years of my life as an adolescent and as a young adult, because I didn't want people to know because of the stigma which I experienced and which I know all kinds of other people around me experience.
Let me get from Jennifer on that. Jennifer, how about it? Have you suffered from stigma?
Yeah, I think that everyone who has ever had contact with the mental health system has a tendency to hide it. I actually first started doing the work I'm doing because I started a group called Mental Health Oppression Survivors. And that was actually for anyone who identified as having experienced mental health oppression, because arguably everybody in society tries to make themselves less because we're concerned about appearing normal. And as a result, people leave all sorts of lively aspects of themselves out because they're afraid of being excluded from society. Because mad is the new bad. There's a lot of where there used to be a sort of good and evil, and now there's a sick and well. And I think part of the reason that people find people from the mental health system frightening is stories get confused. So they'll look at somebody like the person who beheaded the guy, and they'll say, oh, that person did something so bad that they must be mad. And then they reverse reason the same way, unfortunately, and figure that people who seem mad must be frightening and liable to chop off your head.
Marianne, how about you?
You know, when I hear a story like that presented in the media, I feel the media should have an obligation to present 2 or 3 positive stories, because it really, and I'm sure Dr. Einiger can speak to this more so than I, it's a minority of cases that someone that does have a mental health issue is actually violent. It truly is the minority. So there's so many positive stories of people living successfully, productively, contributing to society, contributing to the tax base, doing great things with their lives. It's really unfortunate that gives I believe all mental illness a bit of a bad.
Have you, though, encountered areas in either your work life, your personal life, professional life, where you've been on the receiving end of stigma?
Definitely. Most recently, I was referred to a cardiologist for high blood pressure, and his entire tone and demeanor changed the moment I disclosed to him that I have bipolar disorder and the medications that I was taking. So I felt through the whole process. I mean, he did give me the necessary tests, but I just didn't feel he at one time took me seriously, and that's in the last month that I experienced that. So,
Thomas, as odd as this sounds, we have heard on previous programs that people who are medical professionals, who I guess theoretically are trained on how to deal with people with mental illness, at least a little bit, still stigmatize them. Why does that still happen today?
Yeah, and I'm quite upset that a lot of my colleague healthcare providers are amongst the most stigma manifesting people out there. I think they don't understand. They're scared. The symptoms are strange, and they incorrectly categorize some of the conditions as perhaps not hardcore medicine. And it's very interesting because as a healthcare provider, believe it or not, we suffer from what we call courtesy stigma or stigma by association. Within the medical profession, those of us in mental health care are not thought to be at the same caliber. And I'll tell you the story. You know, my immigrant European parents, I finally got into medical school. It was a big celebration. It was a wonderful thing. Then I trained in family medicine. They were thrilled, and I practiced as a family physician. And I come home one night for dinner, and I say, folks, I decided I'm going to go back to school. I'm going to become a specialist. They go, a specialist? My God, how wonderful. And they go, what are you going to study? I go, psychiatry. And then, oh.
Really? They would have preferred cardiology.
Perhaps. And so that lack of understanding, we cannot use labels and names and pretend nothing exists. But I don't think that for fear of over-labeling. Or we can just use what we know and continue to educate and break down these myths and require, with good policy, that stigmatizing behavior perhaps be reduced. The Mental Health Commission of Canada with the Mood Disorder Society of Canada just did a really great learning module for healthcare providers, for physicians that I helped work on to reduce stigma in healthcare providers at the cma.ca website. So it's a huge issue. And there's tons of work to do, and we're fighting the same battle.
Marianne, do some mental health patients, for lack of a better expression, stigmatize themselves?
I would say I was guilty of that myself, and that's the very reason I'm on the show here today, Steve. I've kept my illness a secret from most. I would be very selective about who I would tell. I would take a long time to ensure I had established some credibility, and I realized in doing that I was stigmatizing myself. So in coming forward and coming on the show today, I've chosen to not do that any longer.
Some of us think the word stigma itself is not a great term, that prejudice and discrimination are better terms because there's actual solutions for discrimination. It's illegal to discriminate, whereas stigma is just kind of, oh, too bad.
So we really need to use tougher language in this case then?
I think so.
Huh, okay. I want to roll some tape. I don't know if you've been watching the series all week, you know that David Irwin, our packaging producer, has done some really wonderful interviews with some people who have been down this road. And this is the clip we're about to play. Jackie Nurse, as part of our Voice of Mental Illness series. This is all on the website. And, well, let's play the clip and then we'll come back and talk. Roll tape, please.
When I was about 12 years old, I remember my mom taking me to see our family doctor because she was really concerned. There was such a drastic change in the way I was. And I remember the doctor telling me that I didn't have anything to be unhappy about, that I had a wonderful mother and a family, and that I should be happy. High school, it got much worse. I had a suicide attempt, and I remember one of the doctors being angry with me and saying, do you have any idea how much time you've wasted, valuable time, people's time that you've wasted? It was really crushing. I had terrible feelings about myself already, and I felt I did waste everybody's time. That's what I was doing on earth, sort of was wasting people's time, and anyone that had anything to do with me.
That's Jackie. And here's Jackie. You came today.
I did.
Glad you did.
Oh, thank you for giving me the opportunity.
You've come a long way.
I have come a long way. It's very much an ongoing struggle, but in my case, I've been very, very fortunate. I did get access to, about 5 or 6 years after that, my suicide attempt, to amazing treatment and care, which was at the Clark Institute of Psychiatry, now CAMH. And as I say, this is an ongoing thing, and it's ongoing today. I still see a doctor that I see weekly, and that ongoing support is what's made the difference. And again, I know one of your shows you spoke about mental health in the workplace and supports. And if anyone can talk about the benefit of something like that, it is me. I was referred to, at the time, a work adjustment program at the Clark, which sort of got me reintegrated back into the workplace. Was the Clark at the time.
Yes,
it's now
okay.
CAMH, yes. And it gave me an opportunity to sort of get my way back into the workplace, and I now have a full-time job at CAMH. And my job at CAMH and the support that I get from my therapist every week, that's my lifeline. And I wouldn't be here today without that. So, my wish is that everyone can have access to care like that, but it does work. And I'm very, very grateful for everything.
The person who tried to take her life those years ago.
Several times.
Yes. How different are you today from that person?
Well, I'm different today in this period. A year ago, I was off work again from long-term disability with the depression. But I mean, it's the support that makes all the difference, and it's support when the times are really bad and support when the times are good. I know that support's still going to be there, and if I have a good period, it's not all of a sudden not going to be there.
Right.
And that's what makes all the difference. Having a job to go to is a huge lifeline, and support from my coworkers, and I mean, I don't know what else to say.
Well, tell me this, Jackie. We've heard many different expressions today of how people who deal with mental illness want to be referred to. How about you?
I have to be honest, I don't have a real problem with the name or anything. It's the treatment and how people accept you, and that they accept you, period, as being someone with an illness. It's no difference than having a physical illness or anything like that. I'm not different from anybody else. I didn't ask to have this happen to me. That's what's important. I totally agree with what was said earlier. I refer to it as I live with depression, because I know I'm not going to obviously now outgrow it or anything. It's something that's with me. I cherish the good times. When the bad times come, I'm very fortunate to have the support that I have.
We're glad you're doing so well, and we thank you for coming out this afternoon to tell us about it.
Can I say one more thing very quickly?
I think you're going to. Yeah.
I am. I just wanted to thank TVO and thank CAMH for Mental Health Matters, period. It's been amazing, not only that it's raising the awareness and that it has, but on a personal level, I never thought I could say I had a positive thing come out of everything that I've been through in my life, and this has been so positive and so helpful to me. And I just want to thank everybody that's been involved with it. It's very, very great. So thank you.
Nice of you to say. Thank you very much. Nice. This is a great success story so far. Are most of them?
A good number of them. I mean, this is exactly why I do what I do, because we do this every day. We alleviate suffering. Believe it or not, we save lives. Me and a whole host of other members of our healthcare team, people are doing great work, and it's very rewarding work to do. And for the most part, when I do share what I think is going on, whatever label or term or diagnosis, whatever, people are usually relieved, because they're usually coming in thinking it's their fault, they're not trying hard enough, they've done something wrong. And when I say, I've seen this before, you're not alone, I know what I think it is, this is what we call it now, and there's things we can do about it, that is tremendously relieving and provides hope for a lot of people, and a lot of people get well. And I think we've just seen a wonderful case of that right here.
We just saw somebody on the live chat, Marianne, say, you got to stop using the word suffering. Stop making us look like victims who are constantly suffering. We are living with, we are making our way through. Do you agree with that point?
I do agree with that point, but there are times of suffering. There are times of suffering, and I've unfortunately experienced one myself, and it was uncomfortable to find the right solution via medication. And that's an uncomfortable process, Steve.
Okay, let's do a little business with the folks at home for a second here. We're a little more than halfway through our program. A reminder that we are here on the downtown campus of the University of Toronto at historic Hart House. This hall has never looked so gorgeous, my goodness. And we're doing Mental Health Matters. This has been the series on TVO all week long. We're live streaming. Our producers are hosting a live chat right now at our special website. It's tvo.org/Mental Health Matters. I see lots of people with Blackberries and iPhones in the audience here tweeting and giving their thoughts on the subject of the day. Tweet at #TheAgenda or at #MentalHealth. While you're at our website, be sure, as I suggested earlier, to check out David Irwin's web-exclusive video series, Voices of Mental Illness, as well as all of our guest blogs, our interactive map of mental illness in Ontario. There's so much more there. It's a great one-stop resource for so much that you might want to know about the issue we've been dealing with all week long. tvo.org/Mental Health Matters. Okay, let's pick up on this here. Here's the scenario. You're riding the bus, or you're on the subway, and there's somebody who's clearly agitated and is making people look at their shoes or keep their nose in their books and, doing everything they can to kind of ignore what's going on. Jeffrey, how should we react?
Well, for one thing, don't glare at them, which you can see a lot. Don't assume that you're under some sort of a threat. That try to understand that someone is obviously going through a difficult time and needs obviously some space.
Some space or support?
Both.
Both.
Some people need space. They need people just to stay away sometimes, and some people need support. Depends on what's going on with them.
Well,
but
how do we know? We're obviously not trained clinicians on the
sometimes
subway.
we don't.
What do you do?
Well, even trained clinicians don't often know for sure. So, and neither do those of us who are been in the system. I can't say that I would know. In fact, I haven't, because I've like probably most people here have experienced a scenario that you've just mentioned on the subway or bus. So trying to basically understand that the person who's experiencing some crisis is going through what they're going through because of something going on in their life, and that we shouldn't automatically assume they should be automatically medicated. If they're going through something that obviously looks like they're going to self-harm themselves or harm someone else, well then obviously one should try to help them.
Let me get Marianne's view on that. Does a passenger approach the person? Do they intervene? Do they say, do you need any help? What's the best approach to take?
In a moment of crisis, it's best that, in my experience anyway, that most people clear away. If I did see someone that was agitated personally, I'd probably approach them and ask them if I could help them with something, speak to them in a very, very calm voice, and respect any boundaries that they may express to me. And if they may wish for me to listen, they may wish to talk to me, or they may wish for me to back away. But either way, just simply respect that and offer a hand of support or encouragement or help in any way I can.
Jennifer, any advice?
There's no magic formula. I do quite a bit of work with police, and I've done some training with police on de-escalating people who are in emotional crisis. But a lot of things people have been saying, pay attention to try and understand whether people need space. Sometimes people they may seem aggressive, but they're actually feeling frightened. So they need people to sort of keep away and not appear like they're going to approach and therefore possibly harm them. And if you're really trying to engage with someone like the police, then you need to make it clear that you're there to help, to try and understand what the person needs, to give the person, in the case of police, choices if possible, so that they don't feel too frightened and needing to defend themselves. And just generally to try and take the person in as an individual and not over-assume things and not try and overly control the situation.
Thomas, you're the chief of psychiatry at a reasonably prominent Toronto hospital. Have you ever had this happen to you when you've been out on the subway or, yes? What do you do?
I probably move seats, to be honest with you.
Move seats.
Absolutely. I think it's normal human reaction. You don't overthink it. If somebody's obviously terribly disturbed and you're concerned, the natural reaction, people will give them some space and move away. So I don't put on my overthinking hat. I act naturally and I give them space. I think that's a natural thing, and I give myself space. And then you might see if it looks like they need assistance or help, you might offer it. You might go talk to the driver. But there's no magic formula because you don't know what's going on. But we can't deny the fact that okay, I'll medicalize it again for a moment. The symptoms of some of these brain conditions involve strange behavior or disturbed behavior or emotionally powerful behavior. It's not like when your liver's not working, your skin goes yellow, you get belly pain. When your brain's not working right, it plays out in your sensory system. You hear things, you see things, your emotional system might go off. That's how I understand some of them. So if someone starts acting exceedingly strangely, like any normal human, I'll probably just back off a little bit till I see what the heck is going on here.
Marianne, can you understand why it would be difficult to build a stigma-free environment when one's natural fears, I guess, probably surface in these circumstances when you see somebody on a subway acting this way? I mean, this is not like just having a broken leg. It looks different, doesn't it?
It does look different. I would say, I would call the comparison to someone having hypoglycemia. So your blood sugar is really low and you're feeling very angry and frustrated right now. Would we stigmatize someone like that? Probably not. Right. And I understand that, you know, in the case of mental health issues, that it can be a little bit more severe than that. But I do draw connections to physical medical conditions because I think mental illness falls under that. It just looks a little different in the way it plays out.
Jeffrey, how about you on that?
Yes, I think it depends on, again, the circumstances. But I think the best support often is for people who are what we now call peer support. It's a term that was come up in the recent years, but I think that's the most important thing, people who've been through these experiences themselves. I mean, I certainly, I think that's essential to helping people because they've been through it. Also, you have to be careful too. I was just thinking while we were talking, have to also understand our relation to them. For example, a woman experiencing a great deal of stress, I think a man has to be pretty careful if he's going to approach her because maybe she's upset about something that happened to her in relation to a man. She doesn't want any man near her. So we got to think, you know, of maybe trying to be as careful as possible if there are people who've been survivors of sexual abuse, you know, and so it wouldn't be a wise thing to go up and, you know, say, how are you doing? That could be actually the last thing. Understood. So you got to be careful, to understand each circumstance and you know, try to figure out where the person is at and where you are in relation to the person.
I read some of Aaron Anderson's piece from the Globe and Mail a little earlier. I want to read another one now. This is from 5 months ago. In some cases, public awareness efforts may have even entrenched certain misconceptions. Stressing the genetic and biological causes of mental illness has also shored up the false belief that it cannot be successfully treated, and that even patients in recovery cannot be competent employees or reliable tenants. The term mental illness has become a misleading catch-all for a range of complex and very different illnesses and disorders. And the most pernicious misconception of all shows little sign of retreat, that the majority of people with mental illness are prone to violence. That still persists. Let's get into this a bit. Jennifer, we have seen some and discussed on our program some what by all accounts are quite wonderful public education campaigns. I know the Bell Canada $50 million campaign is one that has received a lot of attention. I want to know whether you think those campaigns really, at the end of the day, work.
It's funny, I was just having a lively discussion with marketing people on that very topic last week. I think that was a wonderful quote because it's quite correct to say that the emphasis on the biological and genetic has actually increased prejudice, as it turns out, when people research stigma and prejudice, discrimination, because the more people believe that it's intrinsic to the person and unchangeable, the more sort of hopeless they feel about that person. So I think that the information that the trouble with there being prejudice is that people hide the fact that they themselves have struggled, right? So it's actually, if people understood how widespread it was throughout society, perhaps they'd better understand that relatives and friends and coworkers are all people who've had some struggles at some point in their lives. And it's only because we all hide it that people don't realize that. They only see the people who are very, very clearly distraught, and they think that represents everybody who's ever struggled with problems.
Marianne, let me get your view. Do these campaigns really work?
I think that awareness, it's opening up the conversation about it. Are we sending the right message? I think time will tell. I think time will tell. I don't know that the clear message of that treatment and recovery can be known by someone who even has a severe mental illness.
Thomas?
They're doing research on anti-stigma interventions, and public awareness campaigns aren't at the top of the list. The top 2 things of the 5 interventions are contact with persons with lived experience, patients, consumers, survivors, clients, whatever word we use, and structural intervention and structural change. And I'm actually really big on that one, because for stigma to occur, there's got to be power differences. So if you create structures, policies, rules where the power is equal, stigma is going to reduce dramatically. I mean, in numerous emergency rooms where I may have to work in my career in the middle of the night, the mental health space where we assess patients is, sad to say, often the smallest, worst renovated, converted broom closet space compared to the all beautiful high-tech other parts of the house. So if you intervene structurally, that's going to probably do a lot more to reduce stigma. Public awareness is great, but if there's no bite to it, it's only going to go so far.
Okay, let's go out here. We've got a little more than 5 minutes to go, and we'll see if we can sprinkle some questions from the audience in. Hi.
Hi, my name is Priyanka, and this is a question for all of you. On the topic of stigma and how teachers and even doctors themselves can be the ones stigmatizing people, how would you envision an institution stigma-free, whether that be a school or a hospital, where the teachers and doctors don't stigmatize people?
Jeffrey, you work in a university. What does a stigma-free institution look like to you?
Well, thanks for the question. It's a very good question. I would say that it's very much about people, accepting people, giving people accommodations who need those accommodations due to mental health disabilities, as well as the fact that people use a language that's respectful and not isolating people because of their lived experience, but especially at an educational level, to engage people who are students and faculty and staff, all of whom experience mental health disabilities, as equal members. And I include us in the actual experiences of the not only the administration, because I'm actually involved in the administration of one of the programs, but in policy making at the university level, which is essential. Which shouldn't be just, we're token, it should be actual real involvement at the decision-making level.
Thomas, you work in an institution, a hospital.
Yep.
What does it look like to you, a stigma-free institution?
So we're trying to build some policies and training for just that. But mental health discrimination, stigma, is probably the only remaining socially acceptable form of discrimination. You cannot put people of a certain religion, a certain gender, a certain color to have unequal access to accommodations or to care. And yet, we're still fighting that battle with mental health persons. So it's really, to me, getting the leadership and looking at the policies, because it's so in the architecture of the policies, the buildings, the funding models, that people don't even notice they're doing it. And these are kind, otherwise very warm, good-hearted people, absolutely unaware that it's not a level playing field.
So it's more a question of ignorance as opposed to woeful intent, if I can put it that way.
I think so.
My organization spends quite a bit of time working for people's rights, and so we fight discrimination by trying to get people's rights respected under the Charter and under the Ontario Human Rights Code. And sometimes the discrimination is severe, and nothing other than penalty will change it.
Okay, another question here, please.
Actually, I just have to say, when I first was I'm schizophrenic, I can't say it properly. But when I was diagnosed, my mother said, that's not a black disease. I went through a lot of years of struggling with that, so I had to take a hold of my own illness, and I had to educate myself. And today, I'm a support worker for with clients with mental health and drug issues. I'm so glad that they have this forum now that is opening the eyes to people. I know there's a lot of other black women out there that I have not touched yet, and I hope that's going to be my future goal. So I just want to thank you.
Thank you and congratulations. Thank you. Okay. Can I ask, stand by 1 second. As long as we're into the realm of incredibly politically incorrect here, she did raise something, and I want to follow up on that. Thomas Unger said schizophrenia wasn't a black disease.
Right.
Does that mean that mental illness presents itself with some races more than others?
Not generally. It doesn't discriminate. It's just that the form of understanding, the explanatory model, what that culture does with that differs. because you can't talk about it. So certain cultures, we psychologize many of our mental health problems, but the vast majority of people, even in our culture or in Asian cultures, often have physical symptoms that they come in with because that's allowable to be discussed, because there isn't the same feeling. So there might be a couple subtle cultural differences, but for the most part, the illnesses can affect all of us as any other health condition.
Jeffrey?
I did want one correction. Historically, schizophrenia was used more disproportionately against African Americans, and in fact it was called the protest psychosis. And there's a book called The Protest Psychosis by Jonathan Metzl, which it discusses how a large number of African Americans were labeled with schizophrenia during the 50s and 60s, and there is a history. And Suman Fernando has done some research on that in Britain of how Afro-Caribbean men were over-labeled with schizophrenia in Britain, very definite racist connotations.
Let me just mention, in case people assume that white industrialized society is leading the way, there's been 2 studies by the World Health Organization that have found people who they've considered to be to meet the criteria for schizophrenia actually had a better outcome in the third world than they did in the industrialized world.
Let's see if we can get one more question in here. Hi.
Hi. My question is for the psychiatrist. I don't remember your name, sorry. Thomas. You use the word strange behavior, and I had a reaction to that because it assumes that there's normal and proper behavior, and then there was discussion about, yes, it's a natural way to walk away from somebody who exhibits strange behavior, but all those things could be socially constructed, right? And so maybe instead of talking about strange behavior or natural ways of being, we could just talk about diversities of reactions, because to say that someone is exhibiting strange behavior is automatically stigmatizing.
Well, we've heard on previous programs, that's an interesting point. Let me follow up with you.
Sure.
We've heard on previous programs that the use of the word normal is okay. Sounds to me like you don't like it, though.
Well, I think illness is part of being normal, if you want to consider mental illness and like that. I consider it just mental health. But I have a problem with the way how we value the word normal, as in it's the right way to be, because if you have a right way to be, then you might also have a wrong way to be. Mm-hmm. And I don't like that there's a wrong way to be.
Okay, but you're making, and it's okay, I'm just trying to
sure.
kind of understand this better. You're making somebody who suffers from mental illness sound like, when you call it diversity of behavior,
yes,
like it's somebody who's African American or somebody who's Jewish or somebody who's from the Portuguese community or whatever. It's just another one of those
I don't mean
descriptors.
To put it, no, I don't mean it that way.
Okay.
Like I had postpartum depression, and I couldn't, part of it was because I couldn't sleep. I was working nights and taking care of my baby during the day, and I wasn't sleeping. So I was given pills, I was told I had postpartum depression, but the reality was I couldn't get daycare. So I wasn't sleeping. And then when I had tried to commit suicide because of this depression, all of a sudden from medical grounds, I was able to get a daycare spot. I didn't have to wait the 2-year waiting list. And imagine that, I no longer have postpartum depression, nor did I try to kill myself. So what is normal? I don't know. Was it normal for me to try to kill myself? Well, apparently it's a way to torture people, is to prevent them from sleeping. So I feel I was being tortured. I didn't feel I had postpartum depression.
How you doing now?
I'm doing great.
Good to hear it.
Thanks.
Thank you. Anybody up there want in on that?
Yes.
Jeffrey, go ahead.
Yeah, I think that's very good comment. Thanks so much. Right on, actually, I'm saying to myself, right on. It's right to say people have different behaviors, and some people who behave differently, to automatically say everybody should behave in a certain normalized way, it's very dangerous. I mean, because we know people have, not just historically, but in contemporary times, have been pathologized and have been mistreated terribly because of being, they're not behaving in a normal middle-class bourgeois way, and and we know how that's caused people to be labeled and traumatized in different ways. So I think understanding people's differences in the way people behave is very important. It can be very difficult. I'm not pretending it isn't in many instances, but life is part of understanding each other, and it also leads, by the way, to a great deal of people's abilities trying to express themselves. Just because I don't, let's just put it to myself, because I don't understand what you're saying and you're very troubled doesn't mean I have the end-all and be-all of knowing what's going on in your head and what you're trying to say to me. People can say things that we don't understand that still have some kind of meaning.
I actually am going to say one thing that I think everybody will understand. We're out of time.
Okay, there you
That's
go.
the end of our program. I want to thank all 4 of you for coming in today to Historic Hart House and helping us out with this topic. We've really enjoyed doing these stories this week, and we thank all of you for participating here this afternoon.
Support Ontario's public television. Donate at tvo.org.